name's Shahady, and we're here at the Cardiometabolic Risk Summit in Las Vegas, and I'm here with Dr. Jim Matera. He's a nephrologist, hypertension specialist in New Jersey, and he's going to be talking in a few minutes about hypertension and many of the various aspects of it. So what are you going to talk about today?
Today we're actually going to go into the clinic. We're going to do some complex hypertension cases. So what we're going to do is we're going to look with the controversies of the last couple of years with JNC8, the SPRINT trial. We're going to look over the problem of hypertension and how it relates to the changes in medicine that are coming on. But then we're actually going to go clinical. We're going to take it right into the clinic and we're going to present two cases. And we have some audience participation there to decide how you would manage these patients. So we're not looking at the run-of-the-mill patient. We're looking at the patients that you're seeing that are difficult to treat. And what we see is a tremendous variation in how patients are treated. So hopefully today, with the two cases that we illustrate, we'll talk about what's available for patients in order to reduce their hypertension risk.
The SPRINT trial didn't involve any diabetic patients. Can I use that information to help me with diabetics?
That's a good question. And the answer is that really adds a lot of controversy because that's the main, other than that and the adverse effects that came from the intensive control are the two main downsides of the SPRINT trial. When you look at the data, though, you don't think of it that they didn't include hypertensives. They didn't include diabetics. The data looks pretty good,
right. But
how many of your diabetics do you see with hypertension? So I don't know how that translates into that population. We do know that very intensive control in those patients can increase some adverse effects. So I think we're still in a very big dilemma based on JNC8 and the SPRINT trial as to where we need to go with these patients.
I've read in some editorials in some of the big journals that maybe the guidelines are going to change from this January.
That's
ADA.
Yes, that's a very good point. And right now there's a lot more confusion among patients and physicians as to what their goal therapy is. And if you look at some of the European guidelines, they're different than what we have now. So I think we need to come up with some consensus. The problem with JNC8 was that we all know that it was very late coming out, and it really didn't offer a tremendous amount of insight. And many people say, well, that's probably going to be the last JNC report that we're going to get. And there's various reasons for that. There's not a lot of new drugs that are coming out in the field. So I think we need some better consensus guidelines. And I think from the American Diabetic Association, or maybe the American Society of Hypertension, we should look at some of what they're doing.
Right. And as I understand it, although like the ADA still says 140 over 80, 140 over 90, that doesn't mean I'm wrong if when I treat the patient, their blood pressure goes down, say, to 130 over 80.
That's correct. And my patients will always ask me, well, 130 over 80, you're over-treating me. No, that's not the case. That's a target, and I tell them I want that or below. Then I tell them, well, if you're not having adverse effects from that, that's okay to be lower than that. So when we look at that, I use it as more of a ceiling. That's where I want to be, but if you're below that, you're fine.
And I think you made the point there, and I've heard from some of the people on the guideline committee for ADA that the reason they changed it to 140 over 90, one, they didn't have data that supported 130 over 80, but also they felt some physicians were getting people sick by pushing them to that 130 over 80.
Correct. And that's one of the slides I'll show today, is some of the adverse outcomes. And a lot of it is on the hemodynamic effect on the kidneys. And we know our diabetic patients are at high risk for that. And we want to preserve kidney function, but a lot of the adverse effects, not to mention falls and orthostasis, which didn't show a large contingent in SPRINT, but we look at those things and we want to preserve function. That's some of the downside. So,
talking about kidney disease and diabetes, if they have albuminuria, I think we want their blood pressure to be lower.
We do. There's no doubt about that. And most of the guidelines now actually set a lower bar at about 135 over 85 as our target, as opposed to 140 over 90. And that's the target I use in my office, because my goal in those patients is to reduce albuminuria, prevent side effects, and slow the progression of diabetic kidney disease.
Let's talk about how you measure it, because I recently read an article, I think Backus was one of the people that said the SPRINT study, they measured it wrong. They just put something on their arm and left the room, and that made the blood pressure lower. So how do you respond to that?
That's an excellent point, and there's a lot of literature right now being done in where do you check the optimal blood pressure. And we will show some data on that. Do you check it in the office? Do you check it on an ambulatory blood pressure monitor, which some people are now saying you need to confirm high blood pressure with a 24-hour monitor? Or do you have the patient monitor their home blood pressures and how accurate?
So what do you, if I come into your office and I'm being treated, what would you suggest I do?
I'm usually seeing the patients that have already gone through their primary doc and they're more on the resistant side. So I will usually do a 24-hour ambulatory monitor to get an idea. I do have my patients 100% of the time do home blood pressure readings. And I have them do them up to 3, sometimes every day, 3 times a week to every day. And I have them vary the times. So I'm getting a poor man's blood pressure reading. And I do think that those are accurate. And then, of course, they bring their machine in, I check my blood pressure, and if it correlates to theirs, then I'm pretty confident that their home readings are accurate. But I think you're going to see a big shift in the next few years towards looking at home monitoring. I think that's very important as we delve into population health, and I'll show actually a little bit of my own experience with a population health program that I did that shows that empowering the patient does help reduce their risks.
How many times do you feel that the blood pressure elevation is due because they got weight, they got set down, they got a blood pressure cuff on, they got something thrown in their mouth, and the medical assistant's talking to them, and maybe they're sitting on the end of the table with their legs hanging?
Yes, yes. And they probably waited for the doctor for a period of time. Right. They're all concerned. So that's why the office monitors, but if you look at the office pressures, but if you look at the data, that's what we have. Right. That's where all the data comes from. As we start looking at studies on home monitoring, I think we'll see better results. But you're absolutely right. That's not the optimal time. And here, you have the patient who's coming in, they don't know what's going on. A lot of times they're afraid of the doctor. They don't want to disappoint the doctor many times. That's not the best time to be measuring their blood pressure in the office. We used to have a machine in my office called Big Bertha. And it was this big machine. I used to put the patients on in a lounge chair for 15 minutes and watch their blood pressure. We'd take it every 2 minutes. And you'd watch it come down, and then they'd come into the office with me. We actually even toyed with the idea of putting a cuff on each of the chairs in the waiting room to check on that. But I do think that the home blood pressure monitoring is going to be the way of the future.
Well, thank you very much. Appreciate it.
Thank you.